Hi, welcome back. My name is Yenmi, and today I'll be talking about enteral dosage forms. Hopefully you liked my last video and you learned a lot. If you did, like and subscribe. Today's objectives are to review the enteral routes of administration, briefly talk over excipients, and discuss typical enteral dosage forms. So the FDA has over 100 unique routes of administration. That's obviously way too many for me to review, but I'm just going to group them into five broad categories. Those are going to be enteral, parenteral, topical, mucosal, and other/specialized. Enteral administration simply means that the medication being given is administered in a way that the intestines are involved in the absorption process. This can be done through the oral route, the rectal route, using a nasogastric feeding tube, nasojejunal feeding tube, percutaneous endoscopic gastrostomy, or percutaneous endoscopic jejunostomy. Medications that are given via the enteral route undergo what's called hepatic first pass effect. This occurs after the medication has been absorbed across the GI tract. Medications are delivered to the liver via the portal vein. The enzymes in the liver metabolize the medication, and it's highly dependent on the medication itself. For instance, morphine undergoes extensive metabolism in the liver. It has really good absorption, but because of the first pass effect, the bioavailability is only about 33% versus levothyroxine that has less first pass effect. After it's been absorbed and it undergoes metabolism in the liver, the bioavailability is still about 70%. The oral route of administration is the most common and least invasive from the other enteral options. It's the most convenient for patient self-administration. It does have some downsides such as unpleasant taste, it can cause gastric irritation, and it does have a higher first pass effect. It's considered a slower route of absorption. Anywhere between 30 to 60 minutes is typical, but it can be much longer than this. Most absorption takes place in the small intestines. This is because the intestinal membranes are more permeable than the stomach is. Foods can have a wide variety of effects on the absorption. Gastric emptying is usually the rate limiting step in the absorption process. Fatty foods can slow gastric emptying and thus limit the rate of drug absorption. However, sometimes fatty foods can increase absorption. Medications that are poorly soluble can have their absorption increased with foods. Nasogastric and nasojejunal feeding tubes are utilized for patients who are unable to swallow on their own, such as patients who have had a recent stroke. Nasogastric feeding tubes are thin, flexible tubes that range somewhere between 90 to 100 centimeters in length. They're inserted from the nares to the pharynx, to the esophagus, down into the stomach. They're usually not intended to be used for long term, so they're in place for less than about a month. One of the most common reasons we use nasogastric feeding tubes is to aid the stomach in decompression when there is an obstruction somewhere down in the GI tract. Medications such as liquids can be used. However, sometimes medications are not available in a liquid form, and we have to crush medications and mix them with some water and pour them down these tubes. But it is important to refer to the do not crush list because not all medications can be crushed. Nasojejunal feeding tubes serve a similar purpose. They are a little bit different in that they go past the stomach, down into the duodenum to the jejunum. This helps reduce the likelihood of aspiration and vomiting caused by gastroesophageal reflux that can sometimes occur with nasogastric feeding tubes. However, there is less data regarding jejunal medication administration. Enterostomy feeding tubes are used for patients who require long-term feeding. They can either be permanent or temporary. These are feeding tubes that are placed directly through the abdominal wall, into the stomach, or directly into the jejunum. There is a good handy reference out there known as the Handbook of Drug Administration via Enteral Feeding Tubes that covers a wide variety of information regarding these tubes. Some of the information it provides, for instance, it covers flushing protocols, managing interactions between nutrition and medication, advice for off-label uses, which dosage forms can be used, alternative formulations when tablet and capsules can't be used. Rectal route of administration is used for both local and systemic effects. It's still a good option for the patient to self-administer. The rectal route doesn't completely bypass the first pass effect, but only about 50% of the dose is affected. Some of the common local uses are constipation and hemorrhoid relief. Some systemic reasons we use it are for pain and fever relief. Reasons we'd want to use the rectal route instead of the oral route are for medications who have extensive first pass effect or for medications that have limited absorption in the upper GI tract. Or if we're looking for just that local effect in the rectum and in the colon. It's also a good option for patients who are unable to tolerate medications given by mouth because they're having severe nausea and vomiting. A dosage form is the final physical form of a pharmaceutical preparation. These consist of liquids, solids, semi-solids, and gases. It consists of an active pharmaceutical ingredient plus pharmaceutical ingredients. They're designed to be safe and effective. Pharmaceutical ingredients are non-medicinal ingredients, often referred to as excipients. Excipients have many roles in medications. They're there to color, flavor, stabilize, or preserve medications. They also offer practicality when handling of medications. If we were to look at a 100 microgram tablet of levothyroxine, we can see that about 99.9% of it is excipients and only about 0.1% of it is the active pharmaceutical ingredient. Meaning, without those excipients, the tablets would be extremely small and almost impossible to handle. As mentioned in the previous slide, excipients have several uses. There's actually over 400 individual excipients. I've listed a couple on here just as reference, but as you can see, some of them are used as solvents to help dissolve the medication. Some as sweeteners, they make the medication more sweeter. Preservatives prevent microorganism growth. Stabilizers prevent breakdown of dosage forms. Binders adhere powders and tablets. And fillers dilute active pharmaceutical ingredients to desired tablets or capsule form. Some of the common enteral dosage forms are powders, capsules, tablets, lozenges, suppositories, and liquids. Powders can be described as dry, solid, fine particles for internal or external administration. They have a quicker onset of action due to them having a larger surface area and no need for them to disintegrate like the case of tablets. The United States Pharmacopoeia characterizes them based on their size from very coarse to very fine. Very coarse powder particles all pass through sieve number 8, but less than or equal to pass through sieve number 60. Very fine powder particles all pass through sieve number 80 at minimum. Let's take a quick look at powders that are used for inhalation. These usually range between 1 micrometer to 6 micrometers. Larger size particles greater than 10 micrometers would deposit in the mouth or throat, leading to unwanted systemic absorption. Powders intended for the oral route of administration are often mixed with water prior to consumption, such as the case of Miralax. The powder dosage form offers a great deal of benefits, such as their ability to treat skin conditions in the form of a topical powder. They provide patients with difficulty swallowing tablets, such as children's, an option to consume the medication when the powder is mixed with water and changed to liquid form for easy administration. And they also improve the stability of the medication, as is the case for amoxicillin, which in liquid form has a very short shelf life. Capsules are a solid dosage form. They are usually made of gelatin. Gelatin is a protein from animal collagen. These are usually derived from porcine and bovine sources. They can either be hard or soft shell. There are options for vegetarians. These capsules are made of hydroxypropyl methylcellulose and cellulose. They are preservative and GMO free, as well as allergen free, and are kosher and halal certified. Hard gelatin capsules consist of a body and a smaller cap. The benefit of capsules are that they are convenient for self-administration and storage and can sometimes be opened to allow for mixing and swallowing of the contents inside. Hard capsules can range in features. When we reference their size, they can be numbered from 000 to 5 for humans, 000 being the largest and 5 being the smallest. 000 is 26.1 millimeters and 5 is 11.1 millimeters. When you're looking at the weight, it's referring to the weight of the empty capsule. When it says weight capacity, it's the weight it can hold when the capsule is empty. And when it's referring to the volume capacity, that's the volume in the capsule in milliliters. Sizes 00 and 000 may be difficult for most patients to swallow. And a helpful tip is to briefly wet the capsule or apply a swallowing gel as a lubricant. Soft capsules are used for liquids, pastes, tablets, and powders. Tablets are solid dosage forms prepared by compression. They can be scored, which allows for easy cutting of the tablet. They can be administered by oral, buccal, sublingual, and vaginal routes. Tablets can be layered with many designs and formulations. Layered levels can have different active ingredients or allow for drug release implementation or just for cosmetic reasons. They can be coated as well. Film-coated tablets mask the taste, they provide a smooth surface, and they improve stability. Gelatin-coated tablets allow for smaller size, ease of swallowing, and make it easier to detect tamper if they've been tampered with. Enteric-coated tablets are designed to pass through the stomach unchanged. This reduces stomach mucosa irritation. What about pills? Well, pills have been replaced by tablets and capsules. Pills were previously prepared by wet masking and molding. Tablets come in many forms, one of them being chewable tablets. These are useful for patients with difficulty swallowing, such as in the case of children. Effervescent tablets are another form. These are tablets that, when are dissolved in water, produce carbon dioxide. These have a faster onset of action because they are pre-dissolved and they can deliver larger doses. Think of in terms of grams. Orally disintegrating tablets are another form. These dissolve in the mouth, usually within 1 minute, and again, these are useful for patients with difficulty swallowing. There are also vaginal tablets, but these are referred to as vaginal inserts. They are uncoated, oblong, or ovoid shaped. Modified release formulations have had their design changed in a way that either slows the rate of release or alters where the medication is released. When we think of immediate release medications, we think of multiple daily dosing. This can be annoying to the patient. It can lead to missed doses. It can lead to doubling up on the medication accidentally. It can lead to inconsistent blood levels due to those peaks and those troughs that we get with immediate release medications. Time release formulations have a variety of terms. SR stands for sustained release, CR, controlled release, ER, extended release, LA, long acting, DR, delayed release. The United States Pharmacopoeia recognizes two official categories: delayed release tablets and extended release tablets. Delayed release tablets are modified to delay the release of the medication for some time after consumption. They're formulated with acid-resistant or enteric coatings to protect them from the stomach acids. Extended release medications are released over an extended period of time. These are the medications that are abbreviated with SR, CR, and LA. They help maintain more even therapeutic concentrations over a longer period of time. They minimize those peaks and those troughs that we get from immediate release medications. Medications don't always have to be one or the other. Sometimes they're combined. We have medications out there that have an immediate release phase and an extended release phase all combined into one tablet. Lastly, patients should be aware that some medications can leave behind what's called ghost tablets in their stool. This is because the medication will release its content through a tiny hole in the tablet, and the tablet itself will pass unaffected through the GI tract and end up in their stool. The last dosage form I want to talk about today are lozenges. These are solid oral dosage forms that slowly dissolve in our mouth. They are used for local and systemic use. They can contain sugars such as sucrose or dextrose, but there are sugar-free variations for our diabetic patients. They can also be referred to as troches, but this is no longer the preferred term. It's an outdated form of referring to lozenges. This has been your prescription for medication education. I hope you enjoyed today's video. If you liked it, leave me some feedback. Tell me what you liked about it. If you didn't, leave me some feedback. Tell me what you didn't like. Please, I ask that you subscribe and give it a like. Thank you. Have a great day.